Welcome to the deep dive. Today, we're embarking on a really fascinating journey, one that's absolutely fundamental if you're stepping into healthcare, especially for you, our listener, if you're a nursing student right now.
Hmm.
We're talking about the incredible physiological and psychological transformations the human body undergoes during pregnancy. Just amazing stuff.
It really is, and we've dug into quite a few sources here that detail just how intricately a woman's body adapts to support this new life.
Right.
So our mission today is basically to distill all this complex information down into clear, actionable insights for your nursing practice. We'll be hitting the pathophysiology, the signs and symptoms you'll actually see, essential nursing care interventions, and any relevant treatments mentioned.
Okay, so if you're ready to understand the why and how behind these amazing maternal adaptations and what it all means for your patients, let's dive in.
Let's do it.
Okay, let's begin at the very core, the reproductive system. What are some of the most, I guess, dramatic changes we see in the uterus, and how do nurses actually use those observations clinically?
Yeah, the uterus, it probably undergoes the most profound transformation of any organ, really. Before pregnancy, it's, the small pear-shaped organ, weighs about 70 grams.
Tiny.
Yeah, tiny, with maybe a 10 milliliter capacity. But by term, it expands incredibly. It weighs around 1,100 to 1,200 grams. That's over 2.5 pounds, and has a capacity of about 5 liters.
5 liters, that's just hard to even picture.
It is. And this growth isn't just simple stretching. It happens in two phases. First, there's hyperplasia in the first trimester. That's an increase in the number of cells. Then in the second and third trimesters, it's mostly hypertrophy, an increase in the size of those existing muscle cells. They get significantly longer and wider.
Hyperplasia, then hypertrophy.
Yeah.
Okay. So how does this incredible expansion translate into something a nurse can actually, observe and measure?
That's key for clinical practice. These changes become really important markers. You can actually start to feel the uterus palpated just above the symphysis pubis, around 12 weeks gestation.
Okay.
Then by about 20 weeks, it usually reaches the umbilicus, the belly button,
Mhm.
and by 36 weeks, it's way up near the xiphoid process at the bottom of the sternum.
Wow.
So measuring the fundal height at the top of the uterus gives you really valuable information. It's a direct way to track fetal growth and also helps estimate the EDD, the expected date of delivery. It's like a cornerstone of prenatal assessment.
Right. Fundamental. Okay, beyond the uterus, what about the cervix and vagina? What are some of those early, maybe surprising signs a nursing student might notice there?
Good question. The cervix changes quite distinctly. You get increased vascularity, more blood flow, more water content, and it becomes more friable, meaning it's a bit more delicate.
Vulnerable. Okay.
Yeah, and this leads to one of the classic signs, Chadwick's sign. That's a characteristic blue-purple discoloration of the cervix in vaginal mucosa.
Ah, okay. Blue-purple.
Exactly. And you'll also observe Goodell's sign, which is a noticeable softening of the cervical tip. The sources describe it as feeling sort of like the tip of your nose compared to the firmer feel of a non-pregnant cervix, which is more like your chin.
Interesting comparison. And what about the mucus plug we always hear about? What's its actual job?
Yes, the mucus plug. So there's increased mucus production from the cervical glands. This thick mucus forms a barrier, a plug, that effectively seals the cervical canal.
Like a little gatekeeper.
Precisely. Its main job is to be a sterile barrier, preventing bacteria from ascending into the uterus and potentially harming the fetus. And that friability we mentioned, it means slight bleeding after, say, intercourse or even a pelvic exam can happen and is often normal, something to reassure patients about.
Good point. And the vagina and vulva themselves, similar visual changes.
They are, yes.
Yeah.
That increased vascularity also gives the vagina a sort of velvety look, often with that same bluish tint, similar to Chadwick's sign. And then there's vaginal discharge, which increases. It's typically thick, white, and non-irritating. We call it leukorrhea. It's normal. Interestingly, the vaginal environment also becomes more acidic.
More acidic. Why is that?
It's due to increased lactic acid produced by a bacteria called Lactobacillus acidophilus. This acidity actually helps prevent the growth of many harmful bacteria. But, and this is important for you to know, it does favor the growth of yeast.
Ah, so increased risk of yeast infections.
Exactly. That's a common issue in pregnancy, so awareness and patient education about symptoms are key.
Got it. And the breasts. That's often one of the first things women notice, right? A very visible change.
Absolutely. Breasts increase quite significantly in size and feel heavier. This is driven by hormones like estrogen and progesterone. The nipples and the areolae, the darker area around the nipple, they become darker and larger too.
Hmm.
You might also notice these small raised bumps on the areola called Montgomery's tubercles. They're sebaceous glands, and they get more prominent, secreting an oily substance that helps lubricate and protect the nipple. And by about 16 weeks, sometimes earlier, colostrum might be present. That's the thick, yellowish fluid, the precursor to breast milk.
So, with all these changes happening, how do we actually confirm pregnancy definitively? Our sources talk about presumptive, probable, and positive signs. That sounds like a really important distinction for students.
It's absolutely crucial for assessment and how you talk to patients. Let's break it down. Presumptive signs are the subjective things the woman herself experiences and reports.
Like things she feels.
Exactly. Like amenorrhea, missing her period, nausea and vomiting, feeling unusually tired, having to pee more often, breast tenderness or changes, and eventually quickening.
Quickening. That's the first feeling of fetal movement.
Yes, that fluttery sensation. But these are presumptive because, other things could potentially cause these symptoms. They strongly suggest pregnancy, but they aren't proof.
Okay, presumptive is subjective. What about probable signs? More objective.
Yes, probable signs are objective findings that an examiner observes or detects. Things like the uterus getting bigger, visible abdominal enlargement, those cervical changes we talked about, Goodell's sign, softening, and Hagar's sign, softening of the lower part of the uterus.
Hagar sign, right.
Also, Braxton Hicks contractions, those irregular, usually painless practice contractions. And importantly, a positive pregnancy test, which detects the hormone HCG.
So even a positive test is only probable. Why is that?
Well, it's highly likely, but very rarely, certain medical conditions or medications could potentially cause a false positive. So, while very strong evidence, it's still technically classified as probable, not absolute proof on its own.
Fascinating. So what constitutes that absolute, undeniable proof? The positive signs.
Exactly. The positive signs are the ones that can only be attributed to a pregnancy. There were basically three. First, hearing the fetal heart sounds. You can usually pick this up with the Doppler around 10 to 12 weeks. Second is feeling fetal movements by the examiner. This is different from the mother's subjective feeling of quickening. An experienced examiner can palpate distinct movements later in pregnancy.
Right, objective confirmation.
And the third, and perhaps the most definitive early on, is visualizing the fetus via ultrasound. You can see the gestational sac, sometimes even a heartbeat, very early, confirming the pregnancy definitively.
Okay, that makes sense. Presumptive, probable, positive. Got it. So underpinning all of this, which hormones are the, master conductors here driving all these changes?
The hormonal symphony. It's complex, but the key players are definitely progesterone, often called the hormone of pregnancy, because it maintains the uterine lining, keeps the uterus relaxed, and promotes fat storage. Then there's estrogen, crucial for uterine growth, breast development, and that increased vascularity we discussed.
Progesterone and estrogen.
And especially early on, human chorionic gonadotropin, or HCG, that's the hormone pregnancy test detect. Its main job initially is to keep the corpus luteum producing progesterone until the placenta can take over that role.
Right, HCG.
But there are others too. Prolactin ranks up for milk production. Human chorionic somatomammatropin, HCS, which is also called human placental lactogen, or HPL, helps make glucose available for the fetus and prepares the breasts for lactation. And relaxin does just what its name suggests. It helps relax ligaments and soften cartilage, especially in the pelvis, preparing for birth.
It's amazing how coordinated it all is. And as you said, these hormones don't just work locally, right? They create ripple effects throughout the entire body. How do they reshape, say, the cardiovascular system? That seems like a huge adjustment.
A massive adjustment. The cardiovascular system really steps up to support the increased demands, especially the blood flow needed for the uterus, the placenta, and the fetus itself.
So how does blood volume actually change? And what's the key takeaway for a nursing student observing this?
Total blood volume increases dramatically by about 30 to 45%. But here's the interesting part. The plasma volume, the liquid part, increases more than the red blood cell volume. Plasma goes up maybe 40–50%, while red cells increase only 20–30%.
So it's more dilute.
Exactly. This leads to what we call physiologic anemia of pregnancy, or sometimes pseudoanemia. Your hemoglobin and hematocrit levels might look lower on a lab test, but it's often just hemodilution.
Okay.
Now, it's crucial for nurses to recognize this because it's normal. However, pregnancy also increases the need for iron, so true iron deficiency anemia can certainly occur and needs to be watched for. That's why iron supplementation is so commonly recommended or prescribed. You need to differentiate normal dilution from true deficiency.
Right. Important distinction. And the heart itself, how does it cope with pumping all this extra blood?
The heart works harder. Cardiac output, the amount of blood pumped per minute, increases significantly by 30 to 50%. It can reach about 6 liters per minute by the third trimester.
Wow.
And the heart rate naturally increases too, usually by about 15 to 20 beats per minute. It's just adapting to the higher volume and metabolic demand.
Which leads to a really important clinical point, doesn't it? Supine hypotension syndrome.
Yes, absolutely critical for nurses to know. It's also called vena cava syndrome.
Okay, so break that down for us. What is it? What does it look like? And what's the key nursing intervention?
So as the uterus gets bigger, especially later in pregnancy, if the woman lies flat on her back, supine sign, the weight of the uterus can press down on the inferior vena cava, the large vein returning blood to the heart, and also somewhat on the aorta.
Right, compressing the vessels.
Exactly. This compression reduces venous return, which lowers cardiac output, and the woman can suddenly feel faint, dizzy, nauseous, or look pale. Some might even pass out briefly.
Scary for the patient.
It can be. But the intervention is simple and effective. You need to advise her to get off her back. Turning onto her side, especially the left side, immediately relieves that pressure on the vena cava.
Left side is best.
Left side is generally preferred as it ensures maximal relief of pressure on the vena cava. But shifting to the right side is still much better than being supine. It's a really important piece of patient education.
Definitely. Okay, moving from circulation to breathing, how does the respiratory system adapt? Oxygen needs must go up too.
They do. Oxygen consumption increases by about 20 to 30% to meet the needs of the mother, fetus, and placenta.
So how does the body manage that?
Well, physically, the diaphragm gets pushed upwards by the growing uterus, maybe about 4 centimeters, but the chest circumference actually increases slightly to compensate. Breathing becomes more diaphragmatic, deeper, using the diaphragm more.
And does that cause symptoms?
Yes, many women experience dyspnea or shortness of breath, especially later in pregnancy. It can feel uncomfortable, but it's usually a normal result of these mechanical changes and the increased sensitivity to carbon dioxide. It's important to differentiate this normal pregnancy dyspnea from pathological causes, of course.
Good point. Anything else?
Yes, estrogen again. It increases vascularity in the upper respiratory tract. This can lead to nasal stuffiness, congestion, and even epistaxis nosebleeds. Annoying, but generally normal.
Estrogen's everywhere.
Yeah.
Okay, what about the digestive system? We hear about morning sickness, but I gather that's often just the start.
That's often just the tip of the iceberg, yes. Nausea and vomiting, especially in the first trimester, are very common, primarily linked to those rising HCG and estrogen levels.
Right.
But other things pop up too. Some women experience pialism, which is excessive salivation. Kind of strange, but it happens.
Huh. Never heard of that one.
And then there's heartburn, or pyrosis. Progesterone relaxes smooth muscle, including the lower esophageal sphincter, which normally keeps stomach acid down. When it relaxes, acid refluxes up, causing that burning sensation.
Ah, the joys.
Indeed. And that same smooth muscle relaxation plus the pressure from the uterus slows down gut motility. This often leads to constipation, which in turn can contribute to or worsen hemorrhoids.
Constipation and hemorrhoids, common complaints.
Very. Also, the gallbladder can be affected. It might empty more slowly or become distended, which increases the risk of gallstone formation during pregnancy. So as a nurse, you're doing a lot of education on diet, fluids, fiber, and comfort measures for these common GI issues.
Makes sense. Okay, how about the urinary system? I think everyone knows about the frequent trips to the bathroom.
Absolutely. That's a hallmark. What's happening is the renal pelvis and the ureters, the tubes leading from the kidneys to the bladder, tend to dilate. This happens partly due to progesterone's relaxing effect and also some pressure from the uterus, especially on the right side.
Okay, dilation.
Yes. And kidney function actually increases. Renal plasma flow and the glomerular filtration rate, the GFR, go up by 25 to 50%. The kidneys are filtering more blood faster.
Which leads to more urine.
Exactly, hence the increased frequency. But that dilation and slower flow of urine through the ureters called stasis creates a risk. Urine sitting longer makes it easier for bacteria to multiply.
Ah, so increased risk for UTIs.
Precisely. Urinary tract infections are more common in pregnancy and need prompt attention. So you're teaching patients about symptoms like burning, urgency, frequency changes beyond the norm, and the importance of hydration. Also, small amounts of glucose or protein might spill into the urine, sometimes due to the increased load, but significant amounts always need investigation.
Crucial monitoring point. Okay, finally, let's touch on the skin. We hear about the pregnancy glow and less glamorously stretch marks. What's happening there?
The skin definitely shows changes. That glow is partly due to increased blood flow to the skin. Perspiration also tends to increase.
Okay.
A big one is hyperpigmentation. This is thought to be due to increased melanocyte-stimulated hormone, or MSH. It causes darkening of certain areas. Melasma, sometimes called the mask of pregnancy, is that blotchy, brownish pigmentation on the face.
Right. Seen that.
And the linea nigra, that dark line that often appears running down the middle of the abdomen from the belly button to the pubic bone. Existing moles or freckles might also darken.
And stretch marks?
Stria gravidorum, yes. Very common. They're basically tiny tears in the connective tissue under the skin as it stretches rapidly. You see them most often on the abdomen, breasts, hips, buttocks, thighs. They start off reddish or purplish and usually fade to silvery lines after pregnancy.
So nursing care here is mostly reassurance.
A lot of it is reassurance, yes.
Yeah.
Explaining these are normal physiological changes. Also, advising on sun protection is important, as sun exposure can worsen melasma.
Good tip. Okay, we've covered a ton of physical changes, but the psychological adaptation is just as huge, isn't it? How does an expectant mother's psyche adapt, and what's the nursing role there?
Absolutely. The psychological journey is profound. It's common for women to experience ambivalence early on, feeling excited but also maybe worried or unsure. Totally normal to have mixed feelings.
Right, it's a huge life change.
Exactly. Women might also become more focused inward, sometimes described as narcissism or introversion. Their attention naturally turns to their body, the baby, preparing for this change. This is also normal, a way of focusing energy. A key part of this is the maternal role transition. Our sources talk about it in stages. First, accepting the reality of the pregnancy. I am pregnant. Then accepting the growing fetus as distinct, I am going to have a baby. And finally, preparing for the baby and motherhood. I am going to be a mother. It's a whole identity shift.
That's a really helpful framework.
It is. And the nurse's role is vital here. It's about validating feelings, reassuring the woman that ambivalence or mood swings are common and normal. Providing factual information can combat anxiety. It's also about assessing her support systems, encouraging communication with her partner, family, friends, discussing body image changes, expectations versus reality, really offering emotional support alongside the physical care.
Holistic care, truly.
That's the goal.
Wow, what an incredible deep dive. We've gone from, cellular changes in the uterus all the way through these massive systemic shifts and the psychological journey. It really is amazing how the body adapts.
It truly is. And understanding these adaptations, both physiologic and psychological, isn't just interesting trivia. For you as a nurse, it's foundational. It lets you anticipate common discomforts, give accurate information, provide compassionate care, and know when to intervene or seek further assessment.
Right. It helps you normalize the normal and recognize the abnormal.
Precisely. The goal is always to support the woman's health and help her navigate this transformative experience positively.
So for you, our listener, the nursing student, maybe think about what stands out most to you. How do these normal adaptations really highlight just how incredibly designed the human body is for creating and nurturing life? We really hope this deep dive helps you feel more informed and ready to provide that exceptional care.